Hello, everyone, and thank you for joining this AJMC TV peer exchange video program, Pathways to Success, using managed care models to improve clinical and economic outcomes in diabetes and obesity. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University and an associate director of surgical intensive care at the New York Presbyterian Hospital in, you guessed it, New York City. I have the privilege of moderating today's discussion, which will focus on key topics surrounding obesity and type 2 diabetes mellitus in the United States, and the direct and indirect tolls these interlocking conditions take on individuals and the nation's healthcare system. Now, I am joined today by experts with a wide range of experience in providing patient care in a managed care setting. They are Jeffrey D. Dunn, PharmD, MBA, Senior Vice President, VRX Pharmacy Services, LLC, Salt Lake City, Utah. Yehuda Handelsman, MD, FACP, FACE, FNLA, Medical Director and Principal Investigator, Metabolic Institute of America, President-elect, American College of Endocrinology. Maria Lopes, MD, MS, Chief Medical Officer, CDMI Health, Newport, Rhode Island, former CMO, AMC Health, New York, New York, GHI Emblem Health, New York, New York. Carrie Usinarkos, MD, FAAFP, FNLA, Associate Medical Director, Adult Primary Care and Health Management, Colorado Springs Health Partners, Colorado Springs, Colorado. Well, thank you again for joining us, and let's get started. Both obesity and type 2 diabetes mellitus are on the increase in the United States. The percentage of Americans considered obese, defined as a body mass index greater than 30 kilograms per square meter, reached 35.9%. I want you to just think about that. 35.9% in 2012. 15% of Americans have a BMI greater than 35. The numbers are staggering. 12.7 million children, 78.4 million American adults are clinically obese. Now, marching hand in hand with obesity is a rise in type 2 diabetes mellitus. Almost half of all diabetes patients are obese, and the prevalence of type 2 diabetes mellitus increases with increasing weight. More than 22 million Americans of all ages have received a diagnosis of diabetes, of which 90 to 95% is type 2. And yet we believe that only 3 in 4 people with diabetes are even diagnosed. Over the past 2 years, almost 2 million American adults annually received a new diabetes diagnosis. And together, these two diseases have a major impact on healthcare spending in the United States. Annual costs for type 2 diabetes are approximately $245 billion, that's a B, billion dollars, including $176 billion in direct medical expenditures. Health resources use attributed to type 2 diabetes mellitus includes 26.4 million inpatient hospital days, 85.7 million physician office visits, 7.3 million emergency department visits, 361.4 million prescriptions. That's, by the way, 11.8% of all prescriptions in the United States. These numbers are staggering. They're astronomical. More than $1 in $4 spent on neurological, peripheral vascular, cardiovascular, and renal care in the United States is related to complications of type 2 diabetes driven by uncontrolled hyperglycemia. For employers, the costs of diabetes include not only direct expenditures on healthcare, but also costs associated with absenteeism and lost productivity. These costs amount to almost $70 billion annually. All of these costs are predicted to double over the next 20 years, unless current trends can be substantially modified. Obesity-related costs could reach $957 billion in 15 years. That's 2030, not that far away, consuming up to 18% of all U.S. healthcare expenditures. Now, from the vantage point of those charged with managing patients and healthcare spending, the important point is that these costs are escalating exponentially, driven by a 27% increase in type 2 diabetes mellitus prevalence, as well as the changing demographics of patients, for example, younger patients, and changes in treatment options. For example, new therapeutic medications, new prescription meds, more care for advanced complications. All right, so are these trends, I'm going to ask our panel here now, consistent with what each of you is seeing in your organizations? What do you think?
Well, quite the intro. I would say that being from Colorado, we still have the distinction of being the most fit and least obese state. In fact, I looked up the stats this morning. Our obesity prevalence finally has crept up. I think Utah was a close second. But our trends are certainly in the wrong direction. You know, the diabetes trends are 6.7 at the last survey, and they've increased to 7.4%. So this is the most healthy state, if you keep that in mind. Certainly, there's large parts of the country where they don't have the same.
But the numbers are going the wrong way.
They're going
Even in the great state of Colorado, as beautiful as that state is.
Exactly.
What about the rest? What do you say?
Well, I say exactly the same thing. I'm coming from California, that's somewhere in between the healthy and the non-healthy. But I hear about 6.7, 7.2. That's where Mississippi was 10 years ago. So you are not in the right place, Colorado. You need to really take it into account.
So is this just battling states here? California versus Colorado? What are you doing?
It's Denver, it's cold, Los Angeles is warm, and we will look at that in that respect. But no, we need to also recognize that when we are looking at those percentages and we say, in fact, above age 20, it's a higher percentage of people with diabetes. It's approaching 10 to 12%.
10 to 12% above age 20.
Above age 20, and that's average in the country. It's 11.7 to 2011. And then if you're looking at above age 65, 25% of adults above age 65, 25% have diabetes, and another 50% have some kind of a dysglycemia, which is abnormalities of glucose. So 75% of adults above 65 have issues with glucose, and a lot of it has to do with weight.
Do you think that the average doc out there and the average plan manager, probably the plan managers more than the docs, recognizes this rise, this exponential rise? Or is it just something the docs see every day and they almost say, well, it's diabetes?
Yeah. Well, we recognize it, and I totally agree with these trends. The question is, what do we do about it? We'll get into that a little bit later. But if you combine this with life expectancies and the aging population and the impact on comorbidities, and then just look at the drugs themselves. We have more branded drugs. The price increases in these categories are significant. So if you combine all of that, this is a major burden on payers and society in general.
It's a resource burden. Now, Maria, have you seen the diversion? I don't want to use the word diversion, but the need to put resources into diabetes, which is, if you will, removing resources from other problems?
Well, it's certainly impacting resources, and absolutely, and we're doing so much more in terms of member outreach, in terms of the data analytics to identify BMIs, in terms of the physician outreach as well. More options are available in terms of drug therapy, but despite all that, we're losing control over managing diabetes, and part of that is the obesity epidemic.
And I agree with the control. Your question was around resources. The challenge right now that we're facing is there are so many orphaned drugs and ultra-orphaned drugs in specialty categories that are hundreds of thousands of dollars. And so all of our management efforts are going into benefit design and managing these categories of drugs where we're talking about a handful of patients. And so diabetes is never going to go away, and it's still going to be a resource need. But our priorities are subtly being changed, which is not necessarily a good thing in terms of outcomes in this particular disease state.
Well, and that's an issue. Is it possible that because there are near 30 million people with diabetes that we say there's so many of them, we cannot control it anyhow, so let's go elsewhere?
You just give up, throw up your hands and walk away?
And it could be to some extent. Now, we've got 80 million people with prediabetes. So if we would stop them from progressing to diabetes, we would save a lot of money. But do we do that?
Well, and that's where, from a payer perspective, we do not do a very good job, because what we do is very much secondary or responsive. We do not do a good job of preventive care or primary care, and so that needs to change as well.
I think there's also the element of patient accountability, and I know we're going to get into that as well, but with education, with more patient accountability, with more tools to be able to support that patient, hopefully we're going to achieve some degree of success.
I don't want to let that just sit here, because, and I do want to move on to obesity. But when you talk about patient accountability, that's the old blame the patient. The Americans are bombarded by advertising left and right for foods which really aren't doing them any good other than putting on pounds. And it's tough to resist all that. I mean, is it really the patient's fault?
I think it's our job to help patients be successful. It's our job to educate them. But then I think physicians can only go so far. So what more can be added to be able to support the patient their day-to-day, whether it's family, planning, it's addressing the cultural disparities around diet. But ultimately, I don't think we're going to be successful unless we can empower the patient.
How about nobody's going to be successful until somebody stops saying, you want fries with that?
Well, I think also this obesity epidemic, which is part food and part inactivity and part technological advance, and whatever you take, there are lots of things coming on. It is so huge now. This needs now governments to change. In fact, we just finished a couple of weeks ago a consensus meeting of the American Association of Clinical Endocrinologists just on obesity. And we had people from government and payers and insurance companies and patients. And we looked at all of that. One thing was very clear. There should be a nationwide government-directed intervention into try to change the tide of obesity.